Hello and good evening. My name is John Pandolfino. I'm the current president of the ANMS, and it's really my pleasure to welcome you to our webinar this evening. Tonight's webinar is an ANMS virtual symposia, medical procedure education series on pearls of wisdom, ambulatory pH testing. It's co-sponsored by GI Supply and Laborie Medical Technologies. I also want to remind everybody that the following week we will be having one of our virtual symposium focused on basic science. And we were also having our clinical meeting in August, the 5th through 7th. So once again, we look forward to seeing a lot of people at that particular meeting. It's now my privilege to introduce our co-moderators for this evening's symposium. Dr. Joan Chen is at the University of Michigan. She's been there since 2013, and she's the director of esophageal motility. Her clinical and research interests are really revolving around gastroesophageal reflux disease, eosinophilic esophagitis, esophageal motility disorders, and really anything esophagus. She's been a real vigorous participant in a lot of society initiatives, including the Chicago classification, and also has been involved in the ACG guideline for the clinical use of esophageal physiology testing. Dr. Jason Baker, as many of you know, has been a pioneer in many aspects, focused on education, specifically focusing on motility and function testing. He's proctored numerous allied health professionals who perform these particular procedures and really has been an advocate for everybody. He's been involved in multiple meetings, both national and international, and really right now has really become the standard bearer for esophageal motility testing and all sorts of motility and diagnostic testing. So without further delay, I'd like to introduce Drs. Joan Chen and Jason Baker.
Thank you, Dr. Pandolfino, for the kind introductions. I'd like to thank my co-moderator, Dr. Joan Chen, for participating in this session. Today we have our presenter is Barbara Brien. She is the team leader of the Massachusetts General Hospital Motility Lab. The Wing 5 Motility Lab opened its doors in June of 2020. Barbara has led the expansion of the motility lab operation to 2 procedure rooms serving over 2,000 patients per year, offering esophageal manometry, anal rectal manometry, pH testing, and wireless motility capsule testing. Before joining the neurogastroenterology team, Barbara served 14 years as a staff nurse in the medical ICU at MGH and 5 years in endoscopy as a procedural nurse. Barbara has her Bachelor's of Science in Nursing degree from SUNY Plattsburgh in upstate New York, and she lives in Milton, Massachusetts with her husband and 3 beautiful daughters. Before Barbara takes the stage and gives us some pearls of wisdom on ambulatory pH testing, we again like to thank GI Supply and Laborie for sponsoring this session, and for the audience to submit their questions to the Q&A box. And they'll be monitored throughout the session for questions at the end of Barbara's presentation. No further ado, Barbara, the floor is yours.
Good evening, everyone. It's a pleasure to be here this evening with you to talk about the pearls of wisdom of pH testing. And I just want to thank Jason and Joan for co-moderating this with me, and also to thank the ANMS for this opportunity to talk with you tonight. So as I said, we're going to discuss ambulatory pH testing, some pearls of wisdom. Here are my disclosures. So who are these patients that we serve for ambulatory pH testing? These are patients that are coming in with typical symptoms of reflux disease like heartburn, chest pain, things like that. And they've already had a PPI trial with their neurogastroenterologist. Just let me put this aside here. There are patients that are coming in with atypical symptoms of reflux like cough, and they've also had a PPI trial with their gastroenterologist, but are still complaining of symptoms. There are also patients that are being considered for endoscopic surgical procedures and anti-reflux therapy, and patients who have actually had anti-reflux surgery who continue to have symptoms and are uncomfortable. And then in our center, we pH test all of our pre-lung transplant patients. It's part of their lung transplant workup, and that's in order to make sure that they don't have a pre-existing condition that could potentially damage their new lungs. So typical symptoms of GERD are heartburn, regurgitation. There are a lot of atypical symptoms of reflux disease like angina, chest pain. So these are patients that actually go to the emergency room because they think that they're having an MI. They go through an extensive cardiac workup, which is negative, and then they end up seeing one of our gastroenterologists and end up getting pH testing for that. There are patients that have disorders of the throat, patients that come in with pulmonary symptoms like a chronic cough or asthma, patients that come in with hiccups, painful swallowing, and excessive belching. There are definitely some lifestyle decisions that can cause reflux. We know that obesity and smoking can actually cause reflux, and other things that people do, some habits like late night eating, drinking coffee or tea, citrus, spicy foods, chocolate, peppermint, soda, fatty foods, big meals, tight clothing can all exacerbate existing reflux. So what are the reasons why we have, what are the problems that actually lead to reflux? So the biggest one is this transient lower esophageal relaxation. And so I know this is getting a little technical, but essentially, there's a valve where your stomach meets your esophagus. And if this isn't working properly, it's supposed to basically close after you ingest something. It should open up for about 10 seconds and then close and maintain its integrity. However, sometimes there's this long relaxation period with no rhyme or reason. And this is allowing acid to come up into the esophagus. A hiatal hernia can be definitely a problem that can lead to reflux. And as you can see to the diagram on the right here is a picture of a hiatal hernia. And so the lower esophageal sphincter actually gets a little bit of help from the diaphragm. It increases the pressure of the actual sphincter itself. So if you take that away and actually pull part of the stomach up above the diaphragm, now we lose that extra pressure from the diaphragm. And not only that, now we have an outpouching of the stomach that's secreting acid that can actually kind of get stuck in there and lead to more reflux and discomfort for the patients. And we'll get into a little bit more of what a hiatal hernia looks like on high resolution esophageal manometry. So also patients that have a decreased resting tone of their lower esophageal sphincter, patients with asthma that have a lot of interthoracic pressure, patients that come in with increased acid production. Pregnancy can definitely do it. I know that I experienced that with all three of my girls. And I had to be on, I took Pepsid the whole time. Patients that have decreased salivation. So there are some properties of saliva that actually neutralize acid. So that can be one of them. Patients that come in with swallowing disorders, and also patients that come in with slow gastric emptying time. And, these are our patients that come with gastroparesis. So that with actually food stuck in their stomach for longer periods of time, this can definitely lead to reflux. So what are the two different types of pH testing that we offer in an ambulatory setting? So there's two types. One is a catheter-based 24-hour pH testing system, which is actually a catheter that's placed through the nose and into the stomach, and then they have to wear a device. And there's also a wireless capsule study. So essentially a capsule, and I'll go into this in greater detail, is connected to the esophagus itself and can measure up to 96 hours of information of what's happening in the esophagus with acid coming up. So catheter-based. So basically, what we do to get the metrics that we use to measure where we put the placement of the pH catheter, what we're going to do is we'll start off, and then standard of care currently is to do high resolution esophageal manometry. So these patients come in and they have to do a bunch of swallows with a giant catheter down their throat. So it's a little bit uncomfortable, but it does give us a lot of information. Specifically, what we're looking for is the location of the lower esophageal sphincter. And we use that number to place the pH sensor 5 centimeters above that. And again, I'll go into greater detail about how to do that. But the pros of this kind is that you can not only get pH information, you can also get non-acid reflux information. So impedance, fluid coming up that may not necessarily be acid. And the cons are, this is kind of obnoxious. It's on your face, connected to your nose. Patients have to wear it with them. So it's physically can be a little bit uncomfortable, which is why now with the one blessing of COVID is our patients can actually wear a mask to disguise it a little bit. And it's only limited to 24 hours. So here's some slides of what a normal LES looks like. So your lower esophageal sphincter. So up here on the left-hand side, that is your swallow. And if I had all the time in the world, I'd go through esophageal manometry as well, because I find it really fascinating. So here's your swallow. And this is mitigated by your striated and smooth muscles combined. And then over here, there's a transition period as your smooth muscles take over to push the fluid bolus down. Now here's the fluid coming down. The lower esophageal sphincter opens a little bit and then closes and maintains its integrity. And this kind of reads like a weather map, pressures. And then to the right is different types of hiatal hernias. And as I said in the previous slides, I kind of showed you what the hiatal hernia looks like. So as you can see, once you get past the lower esophageal sphincter, sometimes there's this waveform that comes up, and that's your actual hernia. So that can sometimes technically make the procedure a little bit difficult. And I'll talk about ways to get through that and technically be able to conquer the hernia. So here's the placement technique. So when you're about to put in a pH catheter, you've already done your esophageal manometry, you've established the location of your proximal border of your lower esophageal sphincter. We always do a timeout before every procedure. So we go ahead and do that. If the patient feels that they need more lidocaine, we can go ahead and administer that. And so we numb up the nose, and then we're going to place the tip of a lubricated pH catheter into one of the nares and place it down through the oral pharynx and into their esophagus. And you know if you're in the right place when you're placing it. You can kind of feel a little bit of tug every time the patient swallows. And what I do is I continue to advance the catheter until you get a nice pH change. Now, the pH change from about 6 is usually what the normal pH is in the esophagus. And then when you get into the stomach, you're going to get a real pH change, like it's going to go down to 3 or 2. But if they're on a PPI, it's going to be a little bit more subtle. It'll go down to about 5 or so. So you really have to be vigilant as you're advancing the catheter. And as I said, you're going to know if you're in the right place. If you are into the patient's lung, they're going to be coughing their head off. So you know to regroup and restart. And I have some more tricks as to how to avoid that I'll discuss later. So for instance, if you did your esophageal manometry and you determined that the patient's proximal border of their lower esophageal sphincter was 40 centimeters, you're going to go ahead and place that catheter at 35 centimeters at the nair and tape it in place. And usually what we do is we'll tape it at the nose, the side of the cheek, and the side of the neck. And then just have the patient wear it around their neck. And then we're going to take it to the next slide here. So what I'll have my patients do is sip water through a straw. And that's just another tip that I have. I'll have them tuck their chin and to the left sometimes as I'm placing the catheter down. Another trick that I have is to kind of mimic that nasopharyngeal curve. I'll just take the catheter itself and wrap it around my fingers for a few seconds just to get that nice curve. And you can see here on the right what it looks like before you go ahead and place it. And you kind of come at an angle and place it down. And again, once they swallow, you can actually feel the catheter sort of tug down a little bit. So you definitely know you're in the right spot. And also, if it does start to coil, like if it's getting stuck in a hernia or something like that, you'll feel it sort of push back on you when you're trying to advance it. So that's the placement technique. So here are some examples of some of the data recorders that are out there on the market. Here on the left, we have the GI Supply. We have in the middle here, Medtronic, and then this is Diversitech, Santel. And basically all three of these devices are recording the exact same things. They're not only measuring pH, but the patient actually has to participate actively in the data recording. So the patients are going to mark down anytime they eat or drink, anytime they have symptoms, anytime they take their PPI, and anytime they lie down or get up. And I'll go over that a little bit more as we proceed here. Another type of pH testing is the wireless, the Bravo testing. So this is done in conjunction with an endoscopy. So an endoscopist actually deploys this device. So what we do is, and I'll explain this in a slide going forward, but the pros of this is that you can actually get as much as 96 hours worth of data. And they don't have anything in their nose. So the patient's not terribly uncomfortable. They're able to kind of go about their normal activity. Whereas with the catheter one, they might maybe not do all the regular things that they would do normally. And again, it's a little bit more invasive in that you have to have an endoscopy to place it. So with the technique to place the wireless pH testing, we're going to do a timeout. Obviously, the GI physician is going to complete a full EGD exam and then determine where the Z line is. So the Z line is where the esophageal mucosa meets the stomach mucosa. And then the landmark that we use for that is 6 centimeters above where that Z line is. So once the EGD is completed, the endoscopist will remove the endoscope, place it's like on a deployment catheter. The bottom of it has the device itself. The physician will orally advance that catheter with the deployment on it down into the esophagus. And then once we get to the measurement that we decided, so say for instance, we said that the Z line was at 40, was at 46, we'll place it at 40 centimeters. I might have said that the opposite. Sorry, I'm getting a little nervous. Anyway, so once we figure out the landmark 6 centimeters above that Z line, we're going to go ahead and the doctor will say we're in position and we're going to add our suction. So in our center, we actually use a breast pump to get the right amount millimeters of mercury of suction. So we'll have it go up to 510 millimeters of mercury, and then we'll wait about 30 seconds until that, so that some of that esophageal mucosa can actually get into the tiny little port where they're going to deploy that little pin that comes down and keeps it in place. And then once we're in place, the doctor will say, okay, we're ready. And he'll take off the safety guard and go ahead and deploy the wireless pH capsule. And then we're ready to go. The patient, they'll take out the deployment device and then go ahead and repeat, just take another quick look with the endoscope to make sure it's in proper position. So the patient diary, now this is where it's really important to take your time with the patient so that they understand their responsibility in terms of the testing. Now, with all the recorders, including the Bravo device, again, they're going to keep track of when they lie down. They'll press a button when they start and stop. They're also going to keep track of any time they eat or drink. And now I like to be pretty specific to my patients about this. You know, some people like to sip water throughout the day, and I educate them to tell them, well, the physicians pretty much throw away most of the data from when you're eating or drinking, because the pH catheter is going to take on the pH of whatever you're consuming. So instead of, you know, pressing start, stop 1,000 times a day, sit down, drink a whole glass at once, count it as a meal and move on. And I also like to have my patients practice before they leave. And I also provide some phone numbers for them to call if they forgot something, so that they have support while they're doing it. So again, patient teaching is super important here. And you need to kind of meet patients where they're at. And there are a lot of barriers to being able to teach your patients properly. So some of those can include language, cultural, medical literacy is a big one. And then also stress and anxiety. You know, sometimes when these patients come in, they're very nervous and you kind of have to meet them where they're at. Language barriers. So what we do to help with this is, you know, oftentimes if I know there's a patient coming in that doesn't speak English, I'll provide an in-person interpreter. And we're lucky at our center, we have a very large interpreter services service available. So I'll call the night before, make sure we set that up. They'll come in and help do the teaching. And then also translated diaries can help with that. And I find that if you can use non-in-person interpretation, but it just really makes it difficult because sometimes it's hard to hear. So I prefer in person if that's possible. So medical literacy, this is a big one. You know, I think when you're in the medical field for a long period of time, you don't realize that, you know, life inside a hospital is very different from outside the outside world, and patients don't really understand how things work at all. So you can't assume that they know how to fill out a flow sheet or a diary or anything like that. So what I do is I read through the record thoroughly, and then I actually take the time to discuss with my patient, what is your understanding of why you're here today? Why did we order this test for you today? And sometimes patients will be like, well, you know, I've been complaining of these symptoms for a while. I've had a lot of other tests done. And then there's other patients that come in and say, I have no idea why the doctor ordered this for me. So you really have to take the time to help them to understand the importance of filling things out correctly, and specifically symptoms. You know, we want to figure out what's going on with you, and you need to help us by documenting these things correctly. And the other thing I do is if I feel like somebody's like not getting it, I'll bring in a family member. If they're there with somebody, I'll bring in their wife, husband, whatever, to sit down and actually go over the diary with them to make sure they know what they're doing before they leave. And then of course, there's online videos. Sometimes at booking, we refer patients to some online teaching videos that are available. And then specifically with Bravo patients, before they go in for their endoscopy, it's important to do a lot of the teaching ahead of time, because afterwards, they are not going to remember anything you said to them. I mean, I don't know if any of you have had a colonoscopy or an endoscopy. Like, I didn't remember anything until I got home. I was in a fugue. So there's no way I would have remembered how to document anything on a flow sheet. So, creating this therapeutic environment, it's important that you hire the right people for your lab. They have to be empathetic, patient, all that. Obviously, you're going to introduce yourself. I like to use a lot of distraction. So one of the things I often do is before my patients even come in the room, I'm asking them, oh, how was the ride in? What's the weather like outside? Whatever you can do to kind of engage them in light conversation, just to kind of take their mind off of things. I'll use humor as much as possible. And also I like to play music. So I'll ask my patient, what kind of music do you like, whatever. And I use Pandora, Spotify, whatever, put on a station for them. And it usually relaxes them and kind of takes the edge off a little bit. Obviously, you're going to have a clean and private environment, and you're going to make eye contact, all those things that we know as healthcare people, what you have to do. And then obviously explain that the procedure thoroughly, which I've already gone over. So some special considerations to consider are, these patients have been grappling with these symptoms for a long time. This is part of a broad workup. They've had other testing done, the barium swallow, obviously the manometry, upper endoscopies, and so this is, they're here and they've had it. They've been doing this for a while. So, and they're also anxious, but I actually find that because these patients have been grappling for so long, they're actually super motivated to want to get it done and get it done right. So I feel like that actually helps. So why do we do all of this? Okay. Somebody who does the procedures day in and day out, I often don't really know what happens after I transfer all the data over to my physician colleagues. And as I've gone through to do this talk, I've learned about quite a few different metrics that are available for our physicians to work with in order to adequately diagnose our patients with true reflux. And, obviously taking medications is hard for anyone, and you want to be certain that they actually need the medication. So, these next couple of slides that I'm going to go through are quite technical, so I'll just broadly overview them. So one of the probably biggest metrics and most important is the total acid exposure time. So anything greater than 6% is considered pathologic. So that means that, your patient could definitely benefit from some sort of intervention to help reduce that. 4 to 6% is considered borderline or inconclusive, and less than 4% is considered normal. So you wouldn't want to put somebody on a PPI if they didn't need it, obviously. And then we have our symptom-related reflux association. So, is this patient actually having symptoms because of reflux? So, after symptoms occur, are they having reflux and then having a symptom? Does it make sense? Or are they having symptoms all the time that really don't correlate with actual reflux? So these are all metrics that are really important. And as the field develops more, there's been a lot more information on how to adequately treat your patient. So one older measurement, we'll say, that's been around for a really long time is the Demester Score. So this is actually favored a lot by our surgical colleagues. And this is, a score. This is kind of a yes or no. Do they have reflux or not? And they take into consideration many different parameters. So that's, you can look at the slide yourself: total number of reflux episodes, total number of exposure time, upright time, supine time, reflux episodes, the longest reflux episode, and all of those things combined. And actually, this is calculated on all of the software that's out there for ambulatory pH testing, and it gives you a Demester score. So greater than, normal score is considered less than 14.7. Anything greater than that is a yes. Anything less than that is a no. So that's a metric that's used often. And now the Lyon consensus. So this slide's a little difficult for me to decipher, but essentially what I've learned after reading quite a bit about this is that, pH impedance testing can actually really help conclusively decide whether or not your patient has pathologic reflux. So the acid exposure time on a pH impedance test or pH test, acid exposure time greater than 6% is considered pathologic. So you would want to treat that patient if you were a physician. And then if they have an endoscopy in conjunction with that shows grade C and D esophagitis, long segment Barrett's esophagus, or an esophageal stricture, that we definitely know this patient needs therapies. Now, here, as we go down the line, it becomes less and less conclusive. And that's when it's really important for the physician to sort of individualize who this patient is, what's going on with them, and whether or not that they would benefit from different types of therapies. So in summary, understanding the different types of ambulatory testing that's out there, and what works for one patient may not work for another. Ambulatory testing assists providers in clinical management. So as I said in those last couple slides, really important pH testing, that you do it correctly. So you get as much information as you can for your physician colleagues so that they can make the right decision for their patient. And then obviously, it's important as the person doing the procedure to really partner with your patient and help them get through a really tough procedure. If you ask me specifically with the, and if they have to have a manometry study ahead of time, that's can be quite stressful and uncomfortable for patients. And then really for myself, having a better understanding of how these tools are used to affect patient care, it's been really enlightening to kind of have a better understanding of how what I do every day in the lab can affect how my physician colleagues manage our patients. And with that, I thank you for your time, and I look forward to the Q&A. And here are my references.
Nice
Well
job,
done.
Barbara.
Well done, Barbara. Well done. So we got some questions in the Q&A box, and Dr. Chen will start them off, and we'll kind of go back and forth. And I wrote some down too, but anybody else in the audience that has a question for Barbara, or just want some advice on pH testing, please just put in the Q&A box, and Dr. Chen and I will give them to her as we go.
So really good talk. And I'm sorry if you guys are hearing my dog barking. She was so quiet until now, of course.
Isn't that always the way?
Always. So the first question, good question about deploying the Bravo and suctioning for, you have mentioned 30 seconds. And the question is there a rule for 60 seconds, or is it, how definitive is that 30 second?
I find that in my experience, it's really up to the physician.
Yeah. I mean, I was going to say we have 5 providers at Michigan that does Bravo pH placement, and we probably all do it a little bit differently. The initial manufacturer instruction is actually for 15 to 30 seconds. And it's not like the longer you apply pressure, the stronger it's going to hold on to the mucosa. But I will say over the years, I had shifted from 30 to 60 seconds. It only takes 1 or 2 of the capsules that you tried really hard to schedule to fall off prematurely for you to say, what can I do a little bit better? And so
one thing that I didn't say that I should have is that before I even go forward with handing over the deployment device to the physician, is I test and make sure that the suction's working properly on the capsule.
Perfect.
Yeah,
that's very important. So whether it's 30 or 60 seconds, I think, that's going to be different from provider to provider. Great. And then there's a question about documentation of water as a meal. And they said that I do counsel patient to not constantly sip water during the procedure day, but how do you tell patients how to document water drinking? I don't think you meant.
No, I don't tell them not to drink water. I just tell them to sit down and drink a whole glass at once, because, if you're sipping throughout the day, that's going to dilute whatever is in your esophagus. So I really try to just remind them to sit down, drink a whole glass at once, and then just count it as a meal and move on.
Exactly. I think like you mentioned, it's just that when you're eating or drinking, you can't tell if the material is going from this direction, antegrade or retrograde. And so one good example that I think Jason and I had at Michigan was the patient that was sipping on lemonade the whole day because of the throat discomfort. And it was a very positive study, and I was very confused. I wasn't expecting that. And then come to find out that they were sipping something that is low pH the entire time. And so I do the same. I ask them to only try to drink during mealtime so that we don't see things going forward all the time.
Barbara, we have another one. It says, who does the, I think you're doing for sure, but who does the pH studies in your facility? Is it only RN, or does a motility tech?
We have a
perform
motility
procedures?
tech and RNs.
Both, okay.
Mhm.
All right. And then we have another one. This says, have you ever seen complete absence of acid on a catheter study? pH never went below 4, catheter completely straight on removal. Was it maybe placed too high? Maybe you can provide some pearls of wisdom on that. Maybe Dr. Chen can also add on to the response.
I mean, that sounds to me like it wasn't placed appropriately, but it's hard to say. Sometimes it coils and you don't know. I mean, we've had some weird studies that have come through and patients have had to repeat them. I don't know, Joan.
Yeah, I agree. So even in a very positive study, usually you still see the pH kind of go up and down. And Barbara did mention the pH step up from stomach, from the gastric pH to esophageal pH. So I always look for that step up to help know that the catheter was placed in the right location. If it looks like just kind of flat, pH all above 5, 6, you should have some suspicion that the catheter was coiled. Somebody maybe with a hiatal hernia or a large esophagus. These catheters are very flimsy, right? It's a little different from the manometry catheters where you get more feedback from placement.
Yeah, exactly.
Sometimes
it's hard. Yeah.
I would say, Dr. Chen and I did this at Michigan, instructed all our teammates to do it, is that we would place the pH. It's a good practice to get into. You place the pH catheter, and you should start the recording right away. Then when it measures below 4.0, you're in the stomach. Just in case there was an adverse event or a question, you can go back to the very first data point on that pH catheter to verify that you were in acid zone. And
so you're able to see that on the interpretation end.
Yeah.
So you start it before you actually, that's a great idea. We don't do that.
Yeah.
So I'm going to start doing that.
All the omega, the Medtronics, and then the Diversitex, all the same thing. You can expand it out to, I think it's 10 seconds or something. You can see the very first initial data point if you really want to verify that what pH were when you first started. So I always instruct people to do that just to have that data point. And Joan and I did that in Michigan on all our studies. All right, and then one other one, and I'll have Dr. Chen ask one. It says, tips how to avoid coiling in a hiatal hernia with a pH catheter. I think this is a very, as a technical acumen of doing this is probably the most challenging of them all. Yeah.
So usually I'm going to know if we're going to run into trouble, because I will have had a tough time with the manometry portion. So things that I do, I try to be relentless. I just keep going as long as the patient tolerates it. So some things that I'll do is I'll just have them first off, just sit up, stick their chest out, and that can sometimes straighten up the hernia. There are times that I actually have a patient stand up, put their arms over their head. I'll stop at nothing to get it down.
Yeah, I'll add one thing. I'll have Dr. Chen add something if she needs to, but I always say you have them take a really, really large, deep breath.
Yeah.
Like hold it for almost like you're doing massage or yoga. Hold it for 2 or 3 seconds and exhale really bad as they exhale. Just that transient relaxation enough to be able to make you to traverse forward. But those are all good techniques. Dr. Chen, you have anything to add to those?
I think, you guys have covered it all. It always amazes me how all the tricks that you guys know to try. I think one thing that Barbara already mentioned that is the most important perhaps is just trying to feel for the resistance and not push when you feel the resistance.
Mhm.
Because you'll feel the resistance and then you don't because it's now coiled back up.
Yeah.
So
For sure.
yeah, all those tricks.
All right.
So
So I think we're on Mrs. Myers next.
okay. So I'm the meaning or causes of high pH 8 to 10 for a softer basal pH occur in some patients. We really generally don't see pH that high if they're not, ingesting something. In the esophagus, usually, I mean, the neutral is 7, and we usually see below that. It's usually somewhere between 7 and 4. So I'm not sure. I would, really question ingestion, I guess, and or technical issues.
Yeah, I would say, Barbara, the person was asking about high pH between 8 and 10. I would say my suggestion to this was, and Barbara, you add, but I would say I would look at the calibration process. Maybe it wasn't stabilized long enough. There is a time point where catheter has to stabilize to get to the upper limit. So I would go back and look at the methodology of calibration for that. Some wisdom for that issue. I have one I was going to ask you here, might be kind of go through here a little bit, but this was always one that came up quite a bit. The diet, some people you have come in and you'll have some providers say they should eat spaghetti and pizza and everything they can to get to induce reflux. And there's other providers will say we want them to be on a non-acid type of diet to see what happens. So Barb, what is your suggestions or recommendations when people come in, or even drinking alcohol? You get a lot, should I have a glass of wine at dinner? You know what I mean? Like, or should they just stay on their normal diet and see what happens in a real life situation? What would be your pearls of wisdom on that type of
Yeah, so I've had this conversation a lot with my physician colleague, Dr. Stoller. And his answer to that is it really doesn't make a difference. We're going to know if they have prolonged acid exposure time, regardless of what they're eating, is what he tells me. And so what I always tell my patients is we really want to capture what a regular day is like for you. So if you have a glass of wine at night with dinner every night, go ahead and do that.
Yeah.
So I don't tell them to try and induce it or not. I want to get a regular day of their life.
That's pretty much my advice to patients in clinic as well. I tell them not to artificially, because the catheter can be uncomfortable and they may not want to do their normal daily. And I do encourage them to eat and sleep and light activities as usual, because we just want to find out what is usual, inside when they're doing their usual things outside. With some rare cases, though, when I'm really intrigued by patients' symptoms that are triggered by specific foods, I do tell them, well, if something predictably give you symptoms, maybe do that once, not consistently, constantly, but do it once. So that's more for the symptom correlation component, because it doesn't help that much if we're doing this test because of the symptoms, if they have no symptoms during the test. And so if they're not having it consistently, sometimes I do tell them, well, try it once or twice so that we can see what happens during the symptoms.
Here's another one, Barbara. I had this one also written down, so I'd be definitely want to hear your advice on this. Is there an option for the patient to mark down if they are exercising or exerting themselves? For patients that state they get a lot of symptoms during exercise or worsening during or after exercise. So what is your recommendations about exercising? Is there a difference, like going for a walk with your dog or going to the gym? Like, what would be your recommendation, especially at MGH, similar to Michigan and other academic universities? You probably get
I tell them to avoid vigorous activity because I don't want anything dislodged. So that's usually generally what I advise, go for a nice walk, whatever, but, don't go and do like an ab series, especially if you're not, but again, I want to try and capture a regular day in the life, but, not going a soul cycle and sweating it out for 45 minutes.
Yeah, I would add to that. I would say that was always our practice. It makes my practice too, is that go for a brisk walk, but don't go to the gym. And mostly, a lot of it had to do is protect to the data recorder, because you hit the data recorder on a weight or something like that, it could damage it. So there's a little bit of protecting the equipment, and also protecting the tape, because a lot of times they sweat, the tape will come off, and it only takes a couple centimeters, and Dr. Chen can talk to this, it only takes a couple centimeters for those SAPs and SIs and percent of acid in the esophagus to change by a couple centimeters. So
absolutely.
So yeah.
Actually, to your point, Jason, we now we've started documenting in our EPIC, which is our documentation program, when the patient comes back, to say that it was intact and in the proper spot when we took it out.
I think that's smart
as well.
Yeah. I think that's smart. Like Dr. Chen, when she arrived in Michigan, we started doing something different. Is that the team, when they pulled it out, they I don't know if you guys can see my face here, but they pulled out, and you hold it right here, and you pull it out and you hang it, and then you see what the depth is, and you document it. So if it was at 35.5, it may move a half a centimeter, but it'd be right around there. And that also adjudicates if there's a difference in the pH tracing as time goes on. You can annotate it probably at that mark. It was dislodged for one reason or another: coughing, sneezing, vomiting, exercising, or whatever it may be.
Yeah.
So the literature have shown that if there's 1 to 2 centimeter deviation, sometimes that is physiologic. It happens with breathing, it happens with meal, with eating, position change. But anything greater than 2-3 centimeters, especially, then it really is inadequate. And so if you see, greater than 2-3 centimeter deviation, then you might, the provider usually will have to put a little qualifier that the study might be limited because of migration.
Mm-hmm. And I have another question that's always came up quite a bit, and I was curious what your recommendations would be. Is that, so when you annotate symptoms such as coughing and belching, someone can belch constantly, or cough, like micro cough constantly. So what is your recommendations for symptom annotation? Do you do it at the beginning of the coughing, belching spell? Or do you have them record every time they do that, either written annotation or the button annotation?
I tell them to hit the button. And if it's the same symptom over and over again, don't feel like you need to write it down every time. Because if you look in the software, when you go to come up with some of those metrics we talked about, those are all counted, the symptoms, when you press the button. So that's what I tell my patients, like, just keep hitting it when you're experiencing it.
There's a lot of debate over
really
usefulness of, that's completely, correct. But it's controversial in that there's really no definitive answer to some of these vaguer symptoms like cough and, throat clearing. We see that in somebody that's constantly throat clearing and with a catheter in the back of the throat.
And how much of that is more behavioral than actual physiologic?
Right. And so the symptom correlation, some of the gastroenterologists really don't put too much, weight into the interpretation. And there were studies looking at coughing, for example, and they used the acoustic cough detector and to actually to measure cough objectively. And when they looked at the subjective data, when patient recorded cough, they either didn't record it or they recorded when there wasn't cough, they just recalled a cough from like a minute and a half ago.
Okay.
So we're, just human error, and it just is not that easy. And on top of that, there's cough induced reflux. So even when you see a correlation, did cough come first, then inducing reflux? And so there's a lot of debate over that. It's a tool, but I would say it's more a secondary tool, probably.
Yeah. Well, I This has been a great discussion. All the questions that weren't answered here during the session will be put on Doc Matters. So people could go to Doc Matters and the questions will be answered there. I really appreciate Barbara for presenting and Dr. Chen for co-moderating with me. Thank you for everybody who attended this symposia today. We look forward to the next ones and have a great night.
Thanks, Jason.
Thank you.